it'll be on our YouTube channel probably, and you'll get the slides sent out to you after the talk, and then we'll ask your feedback and all that kind of stuff as well. Feel free to put comments, questions in the chat. I'll try and address them at certain points during the morning. And if you have any questions, just put your hand up. I'll try and keep an eye out for them as we go along. Try and be as interactive as we can, and try and use the chat to try and do that. Otherwise, it can be a long, dull morning. We'll have a couple of breaks, about 10-15 minutes, depending on how we get on throughout the morning, and we'll hopefully aim to finish on time, if not a little bit early. I'm going to share my screen, so you should be able to see something there. So just to check, I said I'm an anaesthetist. Let me know what your specialty is, and what I'm going to try just to see if we can get a good variety of people around. And what we'll also try and do is make sure I can try and tailor the session to the specialties we got here. There you go. So we've got the full gamut from GP, psychiatry, mental health, and acute and community. Okay. So what I'm hearing this year generally, and when you're in any kind of management role, and probably on the front, on the kind of in the clinical world, you're hearing lots of noises about this being the worst year. Financially, everything's really tight. You're seeing headlines, cutting staff, everything's really, really tight. Okay. And so here's some newspaper headlines, and what you've got here is this headline's from 2014, 16, 2017, 2025. Can you see the slideshow?
Yeah.
Yeah.
Yeah,
okay,
we can see
fine.
it.
Okay, only because somebody said they can't see anything, so I just want to double check. Okay, that's fine. So why is it so bad this year? So that's the first thing. We're going to try and kind of get a grip on what that is, what's going on. And we're going to try and also think about why is it that finances are so tight every year. So changes in finance and money being limited is a constant issue throughout the whole history of the NHS. Okay. The purpose of today is not to make you look at penny pinching, not to decrease quality of the care we're giving. It's to try and help you navigate the health system, to be able to understand the pros and cons of thinking about the money that we're spending. So every decision that we make as clinicians has a financial impact. So what we need to be is we need to be clinically driven and fight to maintain our quality of care, but aware of the financial consequences and how if we spend or waste money in one area, it can't be spent in another area, and what the best way of making sure that we deliver the best possible care for our patients. So what we're going to cover today, we're going to cover NHS structure, a bit about how services are paid for, a bit about our expenditure, so that's how things cost, and then finally we're going to try and bring it all together and talk about business cases. So that's the kind of structure of this morning. So the key word you'll hear throughout today and in a lot of talks about finance, or when we're discussing finance, is about value in healthcare. We want to give you the best possible value. Value is a repeated thing. Value-based healthcare is a big thing in America. It's increasingly used to look at how funding it flows and how we spend our money. But what we don't really always appreciate is what value is. Okay, so what does it mean? What does value mean? So there's three types of value. There's allocative value, which is how you distribute, allocate value, your money. Okay, so it's mostly done at central government level, at ICB level, and to a smaller degree, lesser degree, at your organizational level. Okay, so that's called allocative value or economic value. What we're going to focus on a little bit in more detail is something called technical value, which is how you make best use of the resources or the money that you've been given. Okay, so you've been allocated the money, how you make best use of it. And that's what I'm going to focus on. It's also called efficient value. And then finally, the thing that we sometimes underappreciate is personalized value. In that different people prioritize and value different things. An example is when they did look at value-based healthcare, they did in a health board in Wales with the help of the kind of the pioneers of value-based healthcare, which is the Virginia Mason Institute in the States, is they asked in a neurology clinic, they asked the patients to rank or prioritize what they wanted out of the consultation, and they did the same thing with the clinicians, the neurologists. And the neurologists looked at diagnosis, preventing further advancement or preventing deterioration, or disease progression, I think was the word they used. And they were the things that rated highest on their what they're aiming for. The patients were more focused on better sleep, being able to work, being able to go out and enjoy the things they enjoy. So often, and in most cases, we align. You know, your values and the patient's value probably do align in most cases, but it is just to be aware that things do differ, and it differs between patients and between us and patients. Okay, and that's called effective value. Okay, so focusing on this concept of technical value. Yeah. So we're going to make it into an equation. And if we were to make it into an equation, what do you think should be on the top line? And what do you think should be on the bottom line? What should the numerator and what should the other thing be? So in the chat, just put in what you think the top line should be, what you think the bottom line should be. What over what? You've got outcomes, cost, output. Okay, so we seem to have got a good understanding that cost is the bottom line. Okay, what are we saying for the top line? For outcomes, any is there a better word for us as clinicians to use? Okay, somebody's got it there. So you've got quality over cost. Okay. That is probably the best definition, okay, of for us to frame value. And the reason is because you have a way of being able to demonstrate changes and benefits in your quality. Okay, so the next question is, in your organization's quality commitment, or in various different bits of paper that you'll see when your organizations talk about quality, there are three domains to quality. It's come up as in a consultant interview question as well. So what are the three domains of quality? What are the three components of quality as per in the NHS? Lots of definitions, but in the NHS there are three domains. Okay. We used one of them a lot. We used one of them a lot so far, which is outcomes. Okay. And the important thing to note when you're looking at outcomes is that there's no specific outcome that is suggested when looking at quality. Okay, so you've got to choose which the most appropriate outcome for whatever you're trying to prove. So you can use any of the standard metrics. So your standard metrics are things like, it can be length of stay, it can be 30-day readmission rate, 30-day mortality, post-op pain, all kinds of different metrics. Okay, but there is no time frame. There is no specific one that you've got to use. Now, a lot of my examples, I apologize in advance, will be surgery or kind of theatre based, because that's where my experience comes from. I'll try and put some other ones in, but an example of a clinical outcome where the standard metrics will be, we'll touch on GP stuff and we'll touch on primary care, but in terms of specific examples, in terms of clinical outcome. So one of my surgical colleagues, they use a particular type of way of closing a big cut in the abdomen, laparotomy wound, and it takes half an hour longer, but it doesn't affect any of your standard metrics: pain, length of stay, readmission rates. Any of your standard stuff would be wouldn't be kind of factored in by that. Okay, so what it does do is at 5, 10, 15 years reduces your incisional hernia rate, okay, which is a very expensive procedure to repair. So an extra 20, 30 minutes has a massive impact, but under the standard metrics, you wouldn't be able to show it. So your outcome, you need to choose the right outcome for what you're trying to show. The second one is patient experience, okay, and the third one's patient safety. Okay, so when you're showing an improvement in quality, you need to show that at least one of those domains is improved, ideally multiple. Okay, so cost. Cost can be divided into two things. Okay, your revenue costs, which are your day-to-day running costs, recurring costs, okay, and your capital costs, which are one-off, non-recurrent costs. And most budgets in the NHS are split into those two, capital and revenue. Yeah. Now, the purpose of showing you this is partly so that when you come to do your business cases or your quality improvement projects, and you want money, you need to demonstrate that the benefit outweighs the cost. Okay. And the guy, Michael Porter, he basically suggested that that's the thing. Your benefit your increase in benefit has to improve the cost. Now, we could knock down and build a new hospital everywhere. We could build multiple new hospitals and replace them. In some situations, it will be worth it, and the improvement in your estates will be and the quality of care you give will be worth the cost. But in some cases, it probably wouldn't be. The other thing that is important to factor in is that if you leave it as simple as quality over cost, then Michael Porter said, if you improve quality, you will reduce cost. The problem is, it may not be the cost to your department. It may not be the cost to or your organization. It may be costs to other organizations. So, any changes we do in hospital might have benefits in primary care. Okay. It may be environmental or societal benefits. If people are in work more, that has a societal benefit, but won't actually be factored into it. Okay. So human cost is it depends how you qualify human cost. So when you talk about human, do you mean by do you mean in terms of workforce, or do you mean in terms of how you quantifying human cost? That's the term is a bit of a misleading one. I'll wait and yeah. Well, that is the question, isn't it? So we got to a stage where we were factoring environmental and societal costs to a degree. Traditionally, it was completely ignored, and it was all focused on whether your your quality improvement project or whatever it is you're trying to push, your service improvement, was going to have benefit to your department or at least the organization. Okay. Over the last few years, historically, more recently, we have factored in environmental and societal costs and benefits that we could achieve by doing that. The next step, and this is where the problem comes in, is that when money gets tighter, it's those things that get kind of factored out or deprioritized. It's environmental societal costs to get deprioritized over a period of time when money gets tight. So capital costs are anything that's a one-off payment, essentially. So most of the time, it's purchasing equipment or building new things that are one-off costs. So that tends to be capital costs. Revenue are your day-to-day running costs, the recurrent costs. Okay, so that's what capital and revenue costs are in this situation. Okay, so we're going to talk about NHS structure now. So the NHS, when it was created in 1948, it wasn't an organized kind of, we built here and planned in that way. They basically nationalized a load of the existing structures that were already there. And that's basically what happened. Okay. And so it tended to be factored in. It ran out of money. Essentially, they nationalized the existing things and it ran out of money. Okay, in the first year, and it's continued trying to evolve in that time. I'll come back to some of the questions in a bit. In 1962, the health secretary at the time decided that they should build a DGH, District General Hospital, for every 125,000 of the population. Okay, to try and, in the post-war period, the baby boom, you had a lot of new towns being built, and so they realized there was a mismatch in where the population was versus where the healthcare was. And essentially what's happened then is that they ran out of money. So it's a recurring theme. In 1974, you had the health authority. So before it was the individual hospitals ran things, and they controlled the system. Health authorities came out in 1974 to try and coordinate things a bit more. And in 1990, they had this thing called the internal market. And this is a time where you had competition. So organizations were required to compete against each other for work. The idea being, or the theory being at least, that that competition would increase quality, okay, and reduce the cost. And it worked for a little bit. Okay, when times were in the boom period, so we had a period of relative boom in the early 90s, it worked. The problem is that as soon as you got to more recession, essentially, you found that the quality aspect massively dropped, and it was all focused on cost. And so the notion of competition kind of didn't work as well. In the 2000s, they had the NHS plan and the introduction of this payment system that was payment by results, where waiting lists were at record highs, and so they incentivized organizations to do more work. Okay, and you got payment by the number of operations or procedures or sessions that you carried out. And what you then found is that you got a lot of private companies coming in and were paid quite a lot of money to get rid of the waiting lists. So at that time, you had the cataract waiting list was really big, and you had lots of private companies that would come in and do literally hundreds of cataracts a week, and that drive the waiting list down. And it worked for that purpose. It has other problems with it. And then the most recent major significant reforms were in 2012. And again, the idea was to try and give more power and more differentiation to local areas, to local health authorities, and try and give clinicians. And in this case, it was primary care who were the kind of the gatekeepers who understand the requirements of their areas, their populations, that to give them power to decide and vary what they could offer. Okay, but built into that, it was there was a requirement for competition. So all the commissioners had to put everything out to competition, to tender. Okay. It was partly because of the procurement rules that were being introduced across the whole of Europe, but partly because they thought that competition would be positive. Again, part of the problem was that between the time that they were thought up and the time they were implemented, we had a global financial crisis in about 2008. So they were thought up by the Conservatives when they were in opposition, and then implemented by them when they came to power. But the world had changed since then. And for the subsequent 10 years, they quite quickly realized that competition was not necessarily a good thing. And organizations needed to work together at times during the kind of recession and austerity. And so for the following 10 years, there was a lot of movement and trying maneuvering within the legal framework. So you had your kind of box that the law kind of put you in, and then we kind of manipulated what we could within it until 2022, when the Health and Care Act got rid of that. So they got rid of that the fact that we had to compete, and they made it so you had to collaborate. Okay, so just trying to address some of the questions that I've had so far. So private companies were like the HCA. There were lots of smaller companies that came in and did a lot of the work in the early to mid 2000s. So it wasn't necessarily the big Americans, and it was much more about the smaller companies that came in and employed people from other parts of the world, and churned through the work. So positives and negatives about it. Yeah, I mean, the NHS is a victim of its own success. It is and one of the problems we're facing now is that people are getting more complex diseases at older age and living to a longer degree. Now, whether that's a positive or a negative, I think that's, you can argue both sides of it. There may be some decisions that people have to, the country has to make as a whole at some point, as to where we want to go. But I think you always want to try and treat people and make them better. Otherwise, you wouldn't be in this particular profession. So the Treasury, ultimately, via Parliament, decides how much money we get in the NHS. And the King's Fund came up with this kind of rule of thumb for how much real terms increases that we need to deliver per year to make improvements in the NHS. So overall, since its conception, we've managed to get a 3.6 real terms increase in funding. Okay. So we're at that point, 3.4, where we're maintaining services, small improvements here and there, and generally doing okay overall. Okay. But as a snapshot, you don't feel it, because particularly over the last 15 years, we've probably not really reached the 3% real terms increase. We got a lot of increase in money during the kind of late 90s and early 2000s. And then we got a lot of decrease in money in the kind of the 2010s, particularly the early side. The subsequent the tail end of this graph is probably slightly skewed in that it includes COVID money, and it's difficult to know how much how much value we got out of that money, because there was a lot of stuff there was definitely a high amount of wastage because of the unknown and because of other issues along to do with procurement. But part of the problem is, and why, the easiest thing is, why don't we just put more money into the NHS? Well, here's the problem. We already take up almost half, just shy of half, of all day-to-day public service spending. Okay. So there are only three real ways to increase this. You can increase taxes. So firstly, it's all about increasing the amount of day-to-day public service spending. Okay, so the total, if you include the total, then your proportion goes up. But even 43%, even if it stays the same, get more money. So you either increase taxes, you either borrow more, or you make cuts to other services. Now, I'm glad I'm not in that political field where I have to make those decisions, because there'll always be somebody who kind of rails against it, and they'll even within the economists, they will argue for different things depending on your particular viewpoint. But this is the kind of area where it becomes very difficult, because which do we do? Do we cut other services? Do we increase borrowing, or do we increase taxes? Ideally, what you want is just the economy to grow. So if your economy grows, then that's the best way of increasing the amount of income that the government gets. So okay, so we said it's 43% of all public spending. Let's have a ballpark. Okay, so in terms of Department of Health and Social Care, Education, Defence, that's what they call the Department of Health, Social Care, Education, Defence, rank them 1, 2, 3 as to who gets the most, who gets the least. And if you want, you can even put a ballpark figure and see if we can get higher, an idea. Okay. So, the Department of Health and Social Care, okay, which doesn't actually fund social care. So this is actually just going to health. It's called the Department of Health and Social Care, but social care is actually funded via the local authorities, so out of their budgets. So it's not actually social care. And it's called the Department of Health, but this is actually health is a devolved entity. So this is actually only for health in England. Okay, so we spend 215 billion. That's a billion with a B. Pounds on health a year. in England, and that's double what we spend on education. And even with the recent increases in defence spending, we're only spending 60 billion. I mean, it's still a lot on defence. And things like the Trident nuclear program, aircraft carriers, all those things. The reason why, whilst they're really expensive, that money is spread out over 20 years. Okay, so that's why we can have millions of pounds worth of things, but actually the actual budgets per year are actually quite small. So of that 215, okay, this is how it's changed over the last few years. Right. The most of it, as you can see from this, is the orange bit, which goes straight to NHS England. And so NHS England revenue budget, so it's your day-to-day spending budget, which is that orange bit. Okay. The grey bit is the capital. It's how much we spend on capital. Build new buildings, purchasing things. And the blue bit at the beginning is Department of Health and Social Care and some of the things it has to fund, and I'll come on to that in a second. So traditionally, historically, over the last probably 10 years at least, the NHS has always overspent on that orange bit. So despite it having the most money in that orange bit, we've always overspent. How much money they're giving us, we not by massive amount, but by a fair amount. And so what we've ended up doing is taking money out of our capital budgets to put into the to plug the hole, which is why we haven't been able to build anything or do any repairs apart from when things are dire. Okay, so while we've kind of broken even just about, we've done it at a cost, and they've really appreciated this. And the fact there's a lack of maintenance, and what they've done is they've said you can't use your capital budgets. You have to spend the capital budgets to build and repair things, and so that's why there's a much more pressure this year on maintaining that revenue budget as it is. This is what was in the spending review. So these numbers are the numbers, how much we've got. Okay, so these are they're not the real. So when we talk about the real terms changes, that's a percentage increases. They are inflation adjusted. These numbers are absolute numbers. So these aren't real terms. So these are the absolute how much money we're getting. If we was to go back to the percentage increases, so these increases are all real terms, so these are inflation adjusted. Okay. So these are the absolute numbers, and because we can't predict what inflation is going to be, we can't tell how much of an impact it's going to have. Yes, you'll have access to the recording. First year, the capital budget is ring fenced. They've said it's been ring fenced for a few years now, but the Department of Health aren't allowed to go over their budget. There isn't, so they have to cut it from somewhere. So when it looks like they're going to overspend, they try and mitigate it somehow. And the most common way of doing it is by using a capital budget. Now, there is no guarantee that we'll be able to do that, but they're trying to put more pressure on to do it. So if we do go massively over for whatever reason, then they may have to go into the capital budget. But they're trying not to. They're trying to put pressure on people not to. That's the key. Okay. So that first blue bit, okay, has to fund 10 agencies. Well, it's 11 agencies, but I'm excluding NHS England. Okay. So how many of these agencies can you name? How many different bodies that the Department of Health and Care, Social Care Fund, can you name? You'll have heard of most of them. There are a couple of them that are a bit more random. And while you do that and think about that, I'm going to see if I can answer some of the other questions that I've seen here. International comparison of spending. So the only real easy way of comparing spending is as a percentage of GDP. And in the UK, we spend a smaller proportion of money than most of the rest of Europe. One of the highest spenders, well, historically, one of the highest spenders of on health as a proportion of GDP is actually the States, which is a private healthcare system, which is quite bizarre. And when you compare I can't speak today, productivity, you'll find that compared with the States, I mean, there haven't been lots of work on this, but compared with the States, we are much more productive for the same amount of money that we get. So, you know, some of these big health ACS, accountable care systems in the States, have multi-billion, as in individual ones have multi-billion pound worth contracts, but they probably do less work than we do per pound. Okay. It's very difficult to compare us with things like Norway and Scandinavia because it's also about population density and how it's all spread out. So Norway, very rich, high amount of GDP, low population, similar way to Canada, and your population is very concentrated in certain places, and so it's slightly more difficult to have a proper comparison because there are so many factors. Right. Let's go through this. So HEE, about 2 years ago, you've been right, but HEE is now part of NHS England. Health Safety Investigation Bureau, yes. MHRA, CQC, nice. We've got a few of those. Some other one that wasn't, but okay, we'll come to it in a minute. So foundation trusts are underneath NHS England. I'll talk about those in a bit. So Department of Healthcare has the MHRA, the Medicines and Healthcare Products Regulatory Agency, which is basically the equivalent of the FDA, which is probably the more well-renowned one, which is the American one, the Federal Drug Administration. They became famous essentially for being the first organization in the world to approve the COVID vaccine. That's probably their big claim to fame. But they kind of approve all the medicines and they approve all the kind of bits of equipment to make sure they're safe for use. Somebody just put in the Health Security Agency. Yes, it used to be called Public Health England, but post COVID pandemic, it changed its name to Health Security Agency. Now, it's a bit of a bizarre way of funding, but essentially the Department of Health basically funds the UK Health Security Agency, but public health as an entity sits at local authority level. Okay, so the UK Health Security Agency then pays local authorities to deliver the public health side of things, and then that money then comes back into the NHS for the screening programs and vaccination programs. So it's a bit of a weird loop of flowing of money there. You've got your NHS Blood and Transplant. So some of these organisations are England specific, but some of these big ones like the MHRA, UK Health Security Agency, and Blood and Transplant are UK wide. The Business Service Authority, which deals with our pensions and prescription charges. NHS Resolution, which is the litigation kind of arm. So they administer the kind of insurance scheme that all the NHS organisations have, the clinical negligence scheme for trusts. And then the Counter Fraud Authority, which is quite a small one. And then you've got these slightly more arm's length bodies, so NHS England, like we said. You've got NICE. It's always maintained the kind of acronym NICE, but the actual what it stands for has changed a few times. Health Education England and NHS Digital have been absorbed into NHS England. Two reasons for that. They want to make sure it's a bit more joined up because basically NHS England had a workforce department and health education had a workforce, and they kind of sometimes said different things. But also, whenever a government of whichever denomination says they're going to protect or ring fence the NHS budget, then it's the health and social care budget that gets cut rather than NHS England's budget. Now, yes, NHS England is getting dissolved. It's getting absorbed into the Department of Health and Social Care, but we don't really know what it's going to be like. So nobody really, it still exists at the moment, which is why it's still in my talk. Yeah, NHS Digital is also taken into NHS England, and then that will be taken into Department of Health and Social Care. So the big problem is that they want to when we talk about ICBs, they want to there's a lot of change going on, and they want to basically reduce a lot of repetition and duplication and cut the number of jobs at those kind of levels. Part of the problem is they can't actually afford the redundancy payments, so it's becoming a bit of a complex thing. So yes, they are due to be dissolved and getting abandoned, but it hasn't happened yet. So they're still in existence at the moment, and they haven't put the roadmap out. We thought it was going to be next year. I'm not convinced it will be next year. You got your regulators, the CQC, Human Fertilization and Embryology Authority, the Human Tissue Authority, Health Research Authority, and the newest one which is the Health Services Safety Investigations Body. Okay, so they're, apart from NHS England, all the other bodies, their budgets come from that little blue bit at the beginning. And if you notice, you would have noticed that occasionally that blue bit budget drops in order to factor to kind of maintain the NHS England's funding. So that's again part of the problem, is that they've not been able to do all the things they want to do because of that. So the majority of money goes from NHS England via the integrated care systems, and I'll talk about those in a bit, to NHS providers. And NHS providers can be GP surgeries, it can be NHS trusts and NHS Foundation trusts. Now, the difference between NHS Foundation trusts is a bit bizarre. So NHS Foundation trusts are essentially autonomous bodies. They're not under the direct control of NHS England and Department of Social Care, Health and Social Care. They have board of directors like all the other organisations, but they have a council of governors above them that kind of oversee or hold the board of directors to account. And the idea was they were going to try and encourage all NHS trusts to become foundation trusts. But they realised quite quickly that the criteria for becoming a foundation trust was purely about managing your finances. And what happened was that there were several trusts that cut lots of quality corners to make sure their finances were on track and above board in order to get become foundation trust status, and then they collapsed and then needed rescuing, and it caused a lot of problems. They also were a bit reckless with they thought they could spend whatever they wanted, but there were some governance issues which meant that any kind of capital spending that those organisations, the foundation trust, did still counted under the NHS England's kind of capital budgets, and it was really pointless. So over the last probably 5 or 6 or maybe 10 years now, various governments have been trying to rein in the power of foundation trusts. So the reason why a trust has become a foundation trust is because you got your autonomy. You didn't have to ask for permission for a lot of things. You could do things. You could keep any money you made or any money you saved to spend on yourself. You had slightly different rules on private work, on how you operated, because you weren't, you didn't even have to have the same contracts. So you could use different contracts for like the Agenda for Change contracts, or even the doctors' contracts. You could go a different way. A couple of trusts tried in the early days to try and change their contracts, and it kind of backfired massively. That's why they've all gone back to using the standard contracts. But they got a lot more independence. But that independence has been slowly being kind of reined back in by the government, by successive governments, because they went a bit rogue for a bit, and then needed kind of bailing out. Okay, so this video, mainly to stop you having to listen to me for the whole time, summarizes a lot of this, what we've said. The numbers are slightly out of date. It's about 18 months old, just over 18 months old. But the concepts still apply. Once we actually have a decision by the government as to what exactly is going to happen with NHS England, we're going to make a new one. But until then, I'll show you this to give you an idea of how the money flows beyond that.
Build a website you love with Wix. For your words.
This animation gives an overview of the structure of the NHS in England and describes how the money flows. How public money is spent is determined by Parliament, and more specifically, the Chancellor of the Exchequer. Money allocated to healthcare is determined by the Spending Review, which is usually every 3 years, and amended annually by the Budget Report. The government department responsible for healthcare is the Department of Health and Social Care, which has the largest amount of pre-allocated public money, with an annual budget for 2023 to 24 of £188 billion. This is divided into £176 billion of revenue funding to cover day-to-day running costs, such as staff salaries and medicines, and £12 billion of capital funding to pay for infrastructure and maintenance costs. Health is a devolved function, so this funding is only for healthcare in England, as social care is funded separately via local authorities. From the budget, the Department of Health and Social Care has to pay its internal costs and fund several executive agencies, special health authorities and arm's-length bodies. The biggest of which is NHS England, which legally merged with NHS Improvement on the 1st of July 2022 as part of the Health and Care Bill. NHS England has now also merged with NHS Digital and Health Education England. NHS England received the majority of the Department of Health budget, with funding for 2023 to 24 of £160 billion. NHS England works via 7 regional teams to support the delivery of the NHS long-term plan. The plan was published in 2019 and outlines the key ambitions for the health service for the next 10 years. To create a service fit for the future and get the most value for patients out of every taxpayer pound. The Health and Care Bill builds on the long-term plan to support integration. NHS England has a budget of £27 billion for directly commissioning services, including some primary care services and public health. It directly commissions military healthcare, health services in the justice system, for healthcare for children, young people and adults across secure and detained settings, and specialised services. There are 154 directly commissioned specialised services, which are grouped into 6 programmes of care: internal medicine, cancer care, the trauma programme, women and children, blood and infection services, and mental health. Over the next few years, NHS England will delegate some of its commissioning responsibilities to local commissioners, with pharmacy, ophthalmology and dentistry services fully delegated by 2023. 9 regional committees are being created to commission specialised services from April 2023. They are joint committees between NHS England and the relevant integrated care systems in each region. Following several years of locally led development, 42 integrated care systems, ICSs, were established on a statutory basis on the 1st of July 2022 as part of the Health and Care Bill. Integrated care systems have four main purposes. They bring partner organisations together to improve outcomes in population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, help the NHS support broader social and economic development. The new ICS are led by an Integrated Care Board, ICB, and an Integrated Care Partnership, ICP. The exact composition of both the ICB and ICP will vary between areas, but as a minimum, the Integrated Care Board will include a chair, the CEO, and representatives from NHS providers, general practice, and local authorities. ICBs replaced clinical commissioning groups, CCGs, and are now responsible for developing a plan for meeting the population's health needs, managing the NHS budget, and arranging for the provision of health services in the integrated care system. The majority of NHS England's budget, £107.8 billion, is allocated to ICBs for commissioning local health services. ICBs plan and commission services for their patients. The Integrated Care Partnership will also include the ICB CEO, local authority representatives and NHS providers, but may also include representation from other organisations. The Health and Care Act has seen a shift to more strategic commissioning and a more collaborative approach to planning care. Allocations are made from NHS England to ICBs as a system funding envelope. ICBs will have the flexibility to manage resources within this envelope to deliver agreed local priorities. ICBs will agree on contracts with providers, with increases expected to be based on aligned payments and incentive basis. Organisations within ICSs have to adopt and adhere to a shared control total, which in effect binds them to meeting a collective target for financial performance. So, in summary, money flows from Parliament via the Department of Health to NHS England, and in the most part, integrated care boards to the organisations that provide patient care.
Okay. Okay. So just to kind of clarify a few things, the first half of that was written by a clinician. The second half was written not. So shared control totals are part of this thing to encourage collaboration. So before ICBs, when we were still in the kind of CCG clinical commissioning groups, the commissions were more spread out. The way that the systems worked was that because of the different types of contracts that everybody was on, the acute hospitals used to lose lots of money. Depending on if you had your community health probably broke even or actually made money. And your mental health, depending on, again, if you were individual or combined as a trust, probably broke even or made money. And so there was no incentive for collaboration between different organizations. But this shared control total means that between all of you, within all the organizations within the ICB or the indicated care system, that you have to kind of adhere to that shared control total, which is, it's not that you have to break even, it's just that between you have to stick to, if you agree that you're going to be only 20 million over, you've got to hit that 20 million over. Okay. And so there's a more collective responsibility, is essentially what it is. One of the things that's happening is that the 42 ICBs that are currently in existence are going to be merged down to about 24, 25. The biggest issue in that is that, as I said, the idea is that you don't want duplication, and you want to reduce the number of people involved. but there's been a few issues with redundancy payments or reallocating these people. The idea is that NHS England will get rid of a lot of its commissioning roles down to these ICBs, and then the specialised commissioning, the small number of super specialised commissioning things will be done at Department of Health level. So it's kind of splitting the role of NHS England, some of it going down to the ICBs and some of it going down to go back up to Department of Health and Social Care. Any questions on that? Sam, I'll come to your question in the second bit, because it's quite a big topic in itself, and I'll try and cover that in a second. So you have your ICB, which basically has your main core. So that they're the actual commissioners. So you have your acute, community, mental health, ambulance, your primary care networks, and your local authorities. Okay, and they make the main decision making. The ICP is to try and bridge that gap between health and social care. That's the main purpose. How effectively it works in different areas definitely varies on who the people are that are different. So in some places you will have police, you'll have often charities that have got interests. It might be housing organisations. There might be other social care bodies that have an interest in that particular region. So they can then have a say in and influence and how that money is spent. Okay, it's not. Yeah, that's probably a good way of saying it. The ICB are the main decision makers around their health bit. The ICP try and kind of link in the social care demands of the population. Yeah, that's basically it. The ICBs don't make money. The people below them can, based on their contracts, depends if they under or over deliver based on on what they're spending. Okay, but I'll come to that in a bit as well. So the Health and Care Act 2022 was basically a tidying up of of what was already in existence. It came into force in 2022. It created it got rid of CCGs, which is clinical commissioning groups, which were primary care led, that had influence from other people, to a more evenly kind of distributed board. And it's made out of this kind of care board and healthcare partnership. They have a duty to collaborate, and you don't have to put things out for tender. What you do find is in some places that you can put things out to tender, you just don't have to. That's the key difference. It depends on the needs of the region. One of the big things it does is tidy up the kind of nomenclature. So previously you had 3 different bodies that were looking after the NHS. You had Monitor, which was to looks after the foundation trusts. You had the Trust Development Authority, which was to help the non-foundation trusts become foundation trusts. So they merged to become NHS Improvement because they decided not to do that. And then you had NHS England, who were the commissioners, saying you've got to have safe staffing, and NHS Improvement, who were the kind of finance or oversight, saying you can't afford to have safe staffing. And they realised that wasn't good, so they merged. And then now you found that actually NHS England probably duplicates a lot of the work that the ICBs and Department of Health does. So now they're splitting those up as well. But one of the key things in that legislation, so previously in the 2012 regulations, one of the things was that the NHS was made to be apolitical. It was put at arm's length, and all the Department of Health and Social Care would basically give them a mandate, say these are our priorities, and it was up to the NHS to deliver them. And there was less power to whoever the Secretary of State was, Health Minister was. Post COVID, that changed. They had a bit of a power grab in that legislation. Pros and cons. Okay, so any questions on any of that? We're probably going to have a probably a 10-minute break, because you've had an hour of listening to me. That's probably enough for the time being. I will stay on for a couple of minutes if you have any questions, but otherwise, grab a drink, stretch your legs, and I will we'll go and do payment systems for the second third. Yeah, happy to answer questions. Yes, so if you're writing a business plan, then your operating expenses are your revenue costs. So you've got to factor them as recurring costs. So that's the key thing, is they are not fixed to a financial year. So you've got to factor that into your ongoing budgetary plans. And capital costs are capital expenditures, yes. So they're one-off payments. The there it is all about, so the idea being that within the ICB, if you, I mean, when you, it depends what you mean by cronyism. The idea will be that most services within a organization should be delivered by the NHS organization. If the NHS organization cannot deliver that, then they'll probably outsource. What's currently happening is that ICBs have contracted out pathways into the private sector, good and bad. The problem with all those things is the private sector will only take things that will make money, which tends to be the low cost, the low complexity, high volume work. And even then, all the complications are dealt with back in the NHS. And if you then hive off all the kind of low complex, high volume work to the private sector, then the NHS never really stands to make. You're just having the more complex stuff that tends to be the loss making ones in the NHS. So increasingly, more and more organisations are trying to bring in house a lot of the low complexity, high volume work. And if you don't make money on those, then you don't stand a chance. So you're and it's all to do with, we'll talk about the payment systems in a minute, but it's all to do with how you put your cost in. And then the other thing with that is that in future, what will probably happen is that, for example, in winter pressures, you'll probably the organisation responsible, so the acute trust or the elective trust or whatever it is, will outsource work that they can't handle to the private sector. So it'll just come from a different pathway, rather than it being a more, it's slightly different competition. It's less competition, more collaboration. That's basically how it's going to work, or how I foresee it working. I have no insider knowledge. I'm mostly self-taught, so I've been doing this for about 10 years on and off. There is formal training on it. I would say that unless you're going to go and teach on it, it's not necessarily. There are courses you can do. I'll talk about those towards the end. There are more study days you can do. We'd have whole day study days. You'll get a copy of all the slides at the end of this session. Eddie will send them out. I've done both. I've done an MBA, and I've done a whole thing on procurement as part of my medical. I did a master's in medical law, so I've done various bits and pieces. I've done business cases at the next level, the first kind of stuff. It is none of it's going to actually necessarily advance you. It's if you find it interesting, there are courses to do. I wouldn't say it's that useful unless you just, I did my MBA because it was a way out during COVID of not being in a COVID ITU. As in, I was in COVID ITU, and then I didn't want to have anything to focus clinically, so I wanted to do something else at that other time. It's not necessarily going to be worth it for most people. Yeah, so there are public sector kind of courses that you can do that are much more low key, and study days that you can do to learn more, and then books and stuff that we can kind of pinpoint you to. I self-funded. Um, uh, I did an online international one, which was much cheaper than a full. I'm not going to get much more money, or if any more money, for doing an MBA. And so the 20,000-30,000 pound cost of an MBA, a proper MBA, I say a proper MBA, a more famous MBA is probably not worth it. If you if there are some that are much cheaper. So yeah, so some will, but you have to get up to CD level, really. And again, I actually don't think it's worth it. I don't think it adds an awful lot to you, apart from if you're interested in it. There are better courses and better things you can do for the money. And even there are lots of leadership management courses that will fund, which are more useful. The various types of fellowships and stuff like that are with the apprenticeship fund, but they have to be there like level 4 or level 7, which is a kind of a way of how they do their grading systems in that field. So NHS finance questions come up in terms of how you're going to deal with it, rather than necessarily, the intricacies of it. Is what your ideas for maintaining the service or improving the service in the current financial climate, and how often does it come in day to day? It depends if you want to buy stuff. If you like your toys and you like you want to fund a whole new clinic or improve your service, then you have to have some understanding of it. If you just want to go in, do your work and come home, then it probably doesn't affect you too much. Am I part of One NHS Finance? Yes, I guess I am. It's a honorary position, let's say. So I was part of the predecessor to One NHS Finance, which was Future Focus Finance. And I've just continued. So I do work for them, or I help them with their work, but it is an unpaid role. Hence, I don't have any inside information. Okay. I hope you managed to uh, hope you managed to get some rest and a better stretch your legs. So One NHS Finance, to give you a background, is it's a program. It's not really a charity or a think tank. It's part of NHS England. It's funded by NHS England, Department of Health, Social and Care. And it's hosted by basically the Healthcare Finance Management Association, HFMA, which is like a professional organization. It's not a professional organization. It's like the equivalent of it's not a trade union. It's just an organization to help support the finance professionals in the NHS. Essentially what it is. It is most of its work is focused on improving the role of finance in the NHS. So it's about improving diversity, improving pathways to help educate the finance people to become a more attractive role for accountants and things like that. A small bit of it, so the one small bit is outward facing, and it's about engaging with clinicians and non-finance professionals, and that's the bit that I help with. So a lot of the work I do is either talk to finance people about how to talk to clinicians, or talk to clinicians about how to work with finance. So that's basically what I try and do. We'll crack on and do a bit more. So Sam asked about procurement and why we don't buy stuff as a group. Well, we do. So you have NHS supply chain. So about 80% of consumables, so most day-to-day syringes, stuff like that, is bought through the NHS supply chain for most organisations in the NHS. There are some that you might find through provider collaboratives. So basically, a group of organisations will kind of come together and pool their resource and negotiate deals, either as part of the NHS supply chain or separate from. And then you've got another group of things that you can. You have something called frameworks. So the NHS framework system is that you've got a load of pre-approved suppliers that you can go to. So if you want a particular thing, you can go direct to the company, but if they are already on the framework, and that means they've done all the kind of hoops they've jumped through. Okay, and there are different ways of putting a process out to tender, depending on which process you're following and how much the value of the of what you're buying is going to be. Okay, and there are some kind of legal rules that kind of come across everything, but as I said, 80% of stuff is bought through the supply chain. A smaller amount is bought through other tender processes, and they tend to be for the more specific stuff. So we've recently done a tender for kind of language interpretation services, and that was we're a big hospital, so that was a big one. But they are fraught with difficulties because of competition rules. So if you put something out to tender, you can't just pick them because you like them. You've got to really justify why you're choosing one over the other and what criteria, and you've got to be very explicit in what your criteria are when you put the tender out and what you're going to judge them against, and then they can take you to court if there's any issues with that procurement process. So you get better deals with that way of doing things, but you have to really kind of be very clear about how you're going to judge them. You can do direct awards, particularly for bits of kit. But again, particularly if they're on a framework, it makes it easier to do that. Now, it's quite time consuming and expensive for companies to get onto framework agreements, onto the framework processes. So, which is why they can cost more. So that's why, buying something you can buy in curries for, I don't know, £100 costs £200 when you buy it through the NHS, because they had to jump through so many hoops to get there, and that's cost them money, and they then pass that money on. It's a weird way of doing things, but that's how it is, and that's part of the complex procurement rules we have, both here and across Europe. It's to make sure that everything's done above board and fairly. I hope that answers that bit of the question. There is a whole separate talk on, we have a full day demystifying finance day thing that we run that has different speakers, not just me. And there is a procurement slot in there. So on our YouTube channel, there should be something, introduction to procurement, that you might find useful if you're interested in that kind of stuff. Right. Payment systems. So unlike most aspects of clinical medicine, how provider organizations get paid changes constantly. And there are different ways of doing it. So the first thing I'm going to do is to kind of go through different building blocks. So there are 7 ways generally that you can pay for things, payment methods of doing this. And every payment system in the world uses a combination, either one or a combination of these different ways of paying things. Okay. The first one's something called block contract. Block contract is a fixed amount. You negotiate that amount based on historic numbers or predicted numbers or whatever it is, but it's a fixed amount. So I will pay you £1 million to deliver community mental health services for this population. Okay. And then once you set that amount in, that's it. You might get it in installments, you might get it one-off, however it is, but that is the amount. Okay, it doesn't actually matter what you deliver. Okay, so if you over-deliver, you lose out. If you under-deliver, the commissioners lose out, but you still get the same amount of money. The benefit is that it is predictable. You know how much money you're getting, the commissioners know how much money they're paying out. Okay, but it doesn't incentivize you to do any more work. Okay, so what I said, I spoke to a group of anaesthetists in Liverpool the other day, and what I said is it was very clear to me when the acute hospitals are on a block contract. Okay, in winter, I know if we're on a block contract or if we're on a kind of activity-based contract, which I'll talk about in a bit. Because on a block contract, you don't get any more money for doing any more work. So therefore, they will cancel things. If there's no beds, there's no pressure, things get cancelled. When on an activity-based contract, there's a lot of pressure because your income depends on how much work you're doing. Okay? So you can kind of tell which contract you're in. So we've kind of flitted in between the various different contracts. So pre-COVID, well, about 5 to 10 years before COVID, most people were on an activity-based contract for everything, which means that particularly in acute hospitals, so the more work you did, the more money you got. In the run up to COVID, a lot of places, because money was getting really tight, they went on to block contract because it was more predictable. Obviously, during COVID and the few years afterwards, we were on a block because nobody could really predict how things were going to go. And then now we're on this combination system, which I'll talk about in a bit. It doesn't incentivize work. That's the main drawback. The block contract is really useful for areas where it's difficult to measure work, how much work is being done. So that's why it's used in community services. That's why it is tend to be used in mental health services, mainly because they tried and get data sharing by using clustering. It wasn't refined enough, so they've gone back to block contract or this blended contract, which we'll come to in a minute. ERF is slightly different. So that's a separate pot of money, which is the kind of recovery fund and enhanced recovery fund, and that's just stopped recently in the last year or so. And so you don't get ERF money, but you get income from other forms if you need to. It's complicated with that side of things. Capitation is so for the GP in the room, this is how the majority of your global sum payment is. So GPs, I'm going to talk about GP payments now because there isn't much in the rest of the talk about GP payments. So GP contracts, there's 2 basic main forms of GP contracts. The main traditional form, which is the general medical services contract, is done at national level. It is given to an individual GP. So that's why most GPs are partnerships, because each individual GP has a GMS contract. The majority of that funding is by capitation. So that's a per patient payment. Okay, so you get X amount of money per patient. Okay, so population based. The problem with capitation is you want to factor in differences in population. So whether it's age, deprivation, socioeconomics, need, various aspects, you want to try and factor that into the capitation model. So it's a weighted example. It's a weighted population you end up providing. The controversy here is how you weight it and how you weight different aspects of it. Okay, so in GP, the majority of on the GMS contract is something called the global sum. The global sum payment is a capitation payment. Okay, and it's the weighting is by a Cahill formula, which is a quite a complex formula, which weights things like deprivation, age, into it. And some people are happy with it, some people aren't happy with it. ICBs and health boards and a lot of other kind of money allocations internationally are done by capitation on a per population amount. So in Scotland and Wales, which have a slightly different system, their health boards are funded by a capitation model. Okay. As I said, the controversy is how you weight it. Okay, so under the capitation model, you get to a point where you want to make sure that you are not losing out on ultimately. And so one of the issues with there was a period, I'm not sure if you're still aware of, where you had a lot of online GP services, and they, in order to use those services, you had to register with them. Okay, and what it meant was that the people that register with these online GP services tend to be younger, fitter patients who were busier, wanted access to primary care services outside of normal times because of work, for whatever reason. Okay, but often they didn't use it very often, and most of them didn't use it very often. And so what happened with the GP model was you had your capitation model basically only reason it works, and one of the reasons it's stopping working at the moment, is that you have a broad population. You get money, some baseline money for some people who barely use the system. Okay, or they use it once every so often. They might go have a quick blood pressure check, or you might go and have a repeat prescription, or you don't use it at all. And then that money basically compensates for some of the high users, because this Cahill formula is not 100%. And so you got your regular attenders, the people with complex comorbidities who need a lot of attention. And if you then take out those patients that are younger, fitter, low use, you basically destabilize the whole GP funding care model. And that basically was almost what happened. Was that, and there was a lot of pushback against that. And they weren't allowed to cherry pick their patients, which is why they kind of merged and do certain aspects of it rather than doing this. So this is not private providers. So this is not like your some companies give you access to a GP out of hours and they're completely private. This is your kind of registered NHS GP is an online provider that covers nationally, but often was based in so capitation is there. To briefly cover the other side of the GP funding stream. So you have most of your money comes out of this capitation model. You get something for it's basically a performance pay, which is your QOF payment, which I'll come to in a minute, and you get other enhanced services if you wish to offer them. The other one that is there is something called the alternative provider medical services contract, which is where it's given to a company for a fixed period of time. Now that's increasingly becoming more popular as more and more companies rather than individuals take on GP services, well, primary care services, and so you have a multi-partner or multi-site GP company that takes on these APMS contracts. Similar kind of capitation model, but there's more room for negotiation because it's not nationally negotiated. And historically, they were only for 5 or 6 years. Now they're 10, 15-year contracts. So primary care networks are groups of GPs in a particular region. So in a particular area. So that's a NHS mandated thing. You've got big not conglomerates, that's a big wrong word, but you've got multi-center, multi-site organizations that might be part of multiple. They might take up a whole primary care network, or they might be part of multiple. So one of my friends is a partner at a GP service in the north, or near Leeds. But they have one branch in York, one branch in Leeds, one branch in some other parts. They've got, I say branch, they've got like 3 or 4 surgeries in each area. Now they are one company that covers the whole of that area, but they're part of multiple primary care networks. Okay, so it's one company, so the contracts are held by whatever the name of the company is, probably an APMS contract. But within that, they are part of multiple primary care networks at a local level. Okay. Fine. And the APMS tends to be a capitation-based funding stream, though it doesn't necessarily have to be. Right, pathway of care. Pathway of care is something that comes in and out of fashion. It is something that has been used in the past for maternity services. And in that situation, you've got one payment for antenatal care, and then you got low risk, medium risk, high risk, one payment for intrapartum care, and you had 5 different levels, and then one payment for postnatal care, and it had a couple of levels. And the idea being you had a lead provider that would get the money, and then they could subcontract out various aspects of the pathway. It was mooted for things like specific patient pathways. So you could do it for a hip replacement. So from the point of referral to kind of optimization, pre-op assessment, the surgery, rehabilitation, the whole thing could be done as a one pathway. It never came to fruition in the end, but that was one of the things that was talked about. Part of the problem is that, and the way maternity services moved away from it is because, say you went in as a low risk pregnancy, you got your payment for low risk. But the problem is if you became high risk, which happens quite a lot, you end up not getting any more money until the intrapartum bit. So you start low risk, you get the lowest money, but you might have had 5 or 6 scans throughout that extra scans because you became medium or high risk, and then you didn't get any more money until the intrapartum kind of process. So it kind of went out of fashion, but it might come back. So pay performance is kind of factored on specific performance targets. So you have your QOFs, which are your GP quality for outcomes framework, and that can be in the standard GMS contract, be about 20-25% of your total income can come from your performance pay. Whereas in the acute community mental health services, it's only about 1%, 1.25% of your money comes from sequins, which is performance pay. It used to be much higher, 2.5%. It's kind of dropped down to 1.5%, and now most sequins are actually optional, so you can opt in to get extra money for sequins rather than it being a penalty. So and only if it's achievable, really. So that's there. Per diem is not really used in this country, but it's basically a lump sum payment per patient per day of care, and you can get level 0, level 1, level 2, level 3 care. So the more complex care, or the more acuity, the higher the acuity of the patient, you might get more money. Okay. It's kind of token notionally used as in terms of excess bed days. So most activity-based payment systems are based on a set number of days that the patient's in hospital, and after that you get kind of a daily payment, which probably doesn't meet the costs of delivery deliberately. So the most common thing is activity-based. So it's the national tariff-based payments in acute, and has been used in mental health. It's not currently used in mental health. It's based on 3 components. You have your diagnosis, which is still based on ICD-10. We haven't moved on to ICD-11 yet. It's probably not going to happen for another 2 or 3 years. You have any procedures that you get, and you get any comorbidities, and it's all based on the coding. It goes into a software program which comes up with something called an HRG, which is a healthcare resource group, and that's what the payment is linked to, the tariff is linked to. Okay, that's what the price list is. And so the more work on this activity-based system, the more work you do, the more money you get. And then you get pass-through payments, where basically the cost of it, how much it costs you to deliver that service, is what you get reimbursed for. And that's for the really super specialized stuff. High-cost chemotherapy drugs is an example, but there are other things that are so specialized that you can't afford them. You know, you're not going to make money on them. There's no way of really kind of measuring the activity level or getting you to be efficient. You just have to deliver it. So that's why it's a pass-through payment. So they are the building blocks. What we're currently using is something called the Aligned Payment Incentive Contract. Okay, and what it is, and it depends on what kind of organisation you have. And this is not for GPs; it's for NHS trusts. So you have a fixed element, okay, which is all your acute activity. So maternity, and if you're, for example, mental health and community organisations, just have that fixed element. Okay. For most of their work. So, and that's an agreed level of activity. So it also includes what's called best practice tariffs. So best practice tariffs are, you have your standard tariff, which might be £100, but if you meet certain criteria, so you tick certain performance indicators. So there's one for neck and femur fractures. So if you have early identification, early surgery, early physio, and various other things like that, you might get £150 if you achieve all those targets in 75% case of times. Then you'll get an extra pay. The payment will be increased. Okay, that's your best practice tariff. That's why sequins have kind of gone less importance, because you've got more of these best practice tariffs. So chargeable overseas visitors, and then CNST is that insurance scheme. So your clinical negligence scheme for trusts, and your premium, insurance premium, are based on your level of risk. So if you do spinal orthopedics, or if you have spinal surgery, sorry, then your risks are higher. If you have maternity or neuro, your risks are higher, so you become your premiums go up. And just like in your kind of car insurance, the more accidents or more claims you've had, the higher insurance premium. So it takes those 2 factors in, your risk and your past claim history, to come up with your premium. Okay, so that's all included into that fixed element. Okay. And then your variable element is all about activity. So that this is as we said, the problem with the kind of block contracts, there's no incentive to do more. So this way, this elective component is to encourage organisations to do more elective work. So that's why you get elective ordinary day case procedures, some outpatient procedures that if they have got a tariff associated with them, some outpatient first attendances, and then some diagnostic imaging included in this elective component. And if at the end of the year you get this final bit, which basically is like you get money taken away if you don't achieve your best practice tariff or your sequin. That's very rarely applied, but occasionally it does. Okay, and that's the majority of contracts. So most organisations will have that contract with several ICBs essentially that fill it. They're in their patch. Okay, this low volume activity contract is a slightly different thing, and that's basically for out of area referrals. So for example, I would assume that there aren't many people from Kent who go and get healthcare done in Leeds. I'm just picking up 2 areas. Okay, so the volume of that contract will probably be quite low. So they'll just negotiate a payment for probably based on the tariffs for that kind of activity. Okay, so that's your low volume activity contract. They tend to be for people where they don't have much activity. I would expect that if you're in Cornwall or Devon, you probably do have a contract with some of the London ICBs because so many people come down there in the summer. So it probably exceeds the £500,000 criteria. So it depends on what kind of areas you're in. Pass-through payments are still a rarity because it's not about the treatment cost necessarily. It's how specialist they are rather than that. It tends to be the high-cost chemotherapy drugs and super specialist areas that have the pass-through payments. Okay, we're going to kind of cover costing and coding and then have another break. So what's the difference between cost and price? What do you think the difference between the cost of something and the price is? Okay, cost is how much you. Yeah, so it's bizarre. Yes, it's what you can charge for it. It's almost what you get paid. So almost the price is how much you get paid for it. Yeah, because sometimes you set the price, sometimes it's not set by you, and the cost is how much it costs you to do it. Okay. So one's your expenditure, one's your income. Okay. Yeah, we're going to keep it quite monetary at the moment, rather than opportunity costs and human costs and all that kind of stuff. But we're gonna try and keep it monetary, just for the moment. Okay. So in an ideal world, we will try. Your organization will aim to the cost should meet the price. Yes, we shouldn't be in a situation in the NHS where that you should be losing money. Simple. That's in my simplistic view. However, the way the price is set is based on an average of how much it costs organisations to do. So currently, every year, each organisation puts in how much it costs them to deliver every HRG, essentially. So every kind of procedure or diagnosis code, how much it costs them to do that. Some places have really got really accurate data. Some places it's not so accurate. And so you get a spread, and some it's a true spread. Some people are very inefficient and have got pathways that are probably too inefficient and probably cost them too much. And some places have got very tight and efficient pathways. But what they do is they take an average. Okay, so they take a spread of costs and they take an average, and then they adjust that. So they factor in inflation. I think this year they put in 4% inflation, so including pay rises. They factor in various costs, and then they put an efficiency factor in. They want you to be more efficient. Okay, so they put an efficiency factor in, which is often less than inflation, but they put that in, and that's the price that's set. Now, with all these things, the NHS kind of tariff or the price list essentially is a guide. It's your recommended retail price, essentially, is what it is. Now, you can, with your commissioners, go, actually, for whatever reason, and you've got to be quite specific with your reason, it's going to cost us more to deliver this. So can we have some more money for it? And they may say yes. They may not, but they may say yes. Okay, so it is not an absolute. It is the recommended retail price, and most places will go for the recommended retail price. But if you have a justification, you can adjust it. Okay. And in an ideal world, what you would do is the people who kind of deliver it for really low cost and really high efficient will share their learning with the people that are not doing it very efficiently. But what what you find is you can't take a pathway in its exact in the exact pathway and replicate it in the same place and deliver the same benefits, because patient populations are different, your estate systems are different, your whole setup might be different. But it's what you can learn from it, and that's what we're trying to do a bit more of. We've not been very good at it traditionally, but we are trying to get better at identifying where pathways are not as efficient as they could be. It's not to say you shouldn't be doing that work, but it's how your pathways, how your clinical pathways work, and are they as good as they can be? Okay. And as I said, you really got to focus on your high volume, low complexity stuff. Okay. If you only do 10, say, again, sorry, it's a surgical kind of example, but if you only do kind of 10 Whipples or 10 esophagectomies a year or whatever it is, a relatively small number, all you need is 2 or 3 of them to have a complication, and everything's skewed, your data is completely skewed. So you can't really use that data to improve your pathways. But if you're doing, loads of epigastric hernias or something else that are the same team are doing that's the work that their pathway is going to be quite tight on. Okay, so it's not about necessarily your big high complex stuff. It's your day-to-day stuff that you want to get sorted. I'm going to go and talk you through this clinical coding. It's quite long, but it kind of highlights some key things that you may or may not know already.
Imagine a place for your money where you're in control. Down.
This animation will give an overview of clinical coding in the NHS. Essentially, clinical coding is the way an NHS organisation records information on what care is given to their patients. It is the translation of the patient record into coded data. It is usually done after the patient has been discharged, and there are strict deadlines that need to be adhered to for data submission. So how does clinical coding work? A patient's hospital stay, from the point of admission to discharge, is called a spell. During their stay, a patient may be under the care of different consultants. This may be due to a change in shift, ward, or speciality. The time period under each consultant is called a finished consultant episode, FCE, or episode of care. So a spell can be made up of a single or multiple FCEs. Clinical coders code diagnoses, comorbidities, complications, and any procedures undertaken for each FCE. So how do we get from treatment to coded episode? All care delivered during a patient episode is documented in the patient notes. Once the episode is complete, the notes are sent to clinical coding, where trained clinical coders carefully read through the notes and allocate the appropriate alphanumeric codes. For diagnoses, they use the International Classification of Diseases 10th edition, ICD-10, which comprises over 16,000 codes. And for procedures and operations, the OPCS Classification of Interventions and Procedures version 4.9, which has over 4,000 codes for procedures and operations. The codes are entered in computer software which determines the Healthcare Resource Group, HRG. Most, but not all HRGs have an associated tariff. An example of this: clinical coders are like detectives, investigating all aspects of their journey from start to finish. You begin by reviewing the documentation, physical and/or digital, for the stay. For example, an elderly woman who had a hip operation 2 days ago. From her medical notes, you find out the main condition being treated, any relevant comorbidities, and the procedure performed. Then, utilising the ICD-10 and OPCS procedure classifications, you find and assign the special alphanumeric codes and record these into the organisation's patient administration system. This coded data can be understood throughout the NHS and beyond, and used to plan for future patient care. What are healthcare resource groups, or HRGs? A healthcare resource group, HRG, is a grouping of diagnoses and/or procedures which are similar in terms of care delivered and the resource used. In order to reflect the complexity of care delivered, HRGs capture main condition treated, investigated, procedures, investigations performed, comorbidities, complications, age, length of stay. Healthcare resource groups offer organisations the ability to understand their activity in terms of the type of patients they care for and the treatments they undertake. Why is clinical coding so important? Clinical coding provides the information that underpins almost all the data flows within the hospital. It can be used for clinical governance, quality improvement, epidemiology, benchmarking, commissioning, financial flows. The challenge. Coders are only able to use information that has been documented in the clinical notes. Incomplete or unclear documentation has been repeatedly shown as a weak link in the data quality chain. Now we know how important accurate clinical coding is to NHS organisations, here are some top coding tips. Clear. Write clearly and legibly, type if possible. Use appropriate language. Check with your organisation, as some have agreements to accept certain terms. Complete. Ensure all diagnoses and procedures are recorded in detail. Document all relevant comorbidities. Understandable. Abbreviations and shorthand cannot be coded. Coders are not allowed to interpret investigations or numbers. Accessible. Make sure the coding team know where key information is recorded.
Let me just try and move this on a second. No. Oh. Okay. So the aligned payment incentive model is the contract for secondary care at the moment. It is probably going to be renewed next year. They were talking about changing it, but about last week they decided it was probably not going to be changed. We don't really always know the exact nature of the payment model until about December, before the April changeover. That's when they confirm with the planning guidance. They often put some kind of guides out beforehand and some feelers, but it's never really confirmed until about December time, most commonly on Christmas Eve. So AI would be good. It depends on what kind of system you are. So if you're on a completely electronic patient record, so if you don't have any physical paper notes, you're on a completely electronic paper record, then it is likely that AI will probably be used sooner rather than later. With written records, the kind of character recognition, people's writing, means that it probably isn't quite there yet to be able to do that, because just scanning all those documents in is too time consuming. We are in this weird hybrid where we have a partial EPR, but we also have paper notes. And so our coders only code from electronic notes, whereas we still haven't got to that stage where we're predominantly not documenting online on the electronic system and not in the paper notes. So it's difficult to know what proportion of trusts are still paper-based, because some are hybrids. They haven't got a full EPR. And I would say a lot of trusts are in that situation where, if you've got if you're in Manchester or one of the big London hospitals, you're probably completely EPR on one of the off-the-shelf ones. A lot of places are using these kind of ones that are being developed in-house or with a particular company, and it may not be completely ready yet. So that's where the problem is. So they might say they have an EPR, but will it's fully formed or not and used for clinical notation is a different question. Competition rules. They tried. So they tried about 10 years ago to try and come up with a single unified EPR, and it wasted billions of pounds because everybody had their own interpretation of what they wanted. And then there was going to be a whole issue with competition. And so, yes, there was there are, so now it's all about interoperability. So it's trying to make sure that whatever data you put into one place is put into another, is transferable and readable. And this is where it gets complicated, because it's about how they feel, how the fields are classified, rather than anything else. And then until the NHS has its own kind of machine language learning model, there's lots of confidentiality issues. Yeah, so there's a lot of potential issues in introducing AI at patient level, so our notes level. There's a lot of AI being talked at to look at operation stuff that's non-confidential work, information, so non-sensitive information. So looks at processes and how the numbers and data are being analysed in the background like that, but the kind of patient level stuff cannot be currently. So yeah, cost is the money spent to deliver service, resource is what's used to treat the patient, and activity is each thing. So the whole costing process. So what we're trying to do now is understand where we are spending our money, so that we can try and work out where the inefficiencies are, or where the cost issues are. And so what they've tried to do, and this is, I've stolen this from Manchester University, because they've got a great costing team and a good coding team as well. But they have, you're going to take in your various non-patient costs. You then have your patient-facing costs. Okay, so your ward costs, theatre costs, and then you allocate it somehow. Now, how you allocate it might be by number of minutes on the ward, multiply acuity. It could be how much, how you divide the cost of theatre, running theatre, by how many minutes that each patient's in theatre, number of type in scans. So some of it. So if you've got a, so whilst we're not paper-based, our radiology and our pathology, and we have a electronic prescribing system, so we can actually get that level of data to patients relatively easy. This system works really well in surgical specialties, because we tend to have, particularly electives, because it tends to be a simple pathway. It's really difficult, it's harder in medicine, in general medicine type places, because you don't always know the level of acuity or how many interactions a nurse or a healthcare worker has with a patient, to get a true idea of the costs. And it's almost impossible in mental health, because the data classification, clustering, they tried, didn't really give you the kind of detail that they wanted. So mental health, much harder to be able to capture data. In fact, the only reason they introduced clustering and that kind of trying to introduce that as part of the payment results is to try and get that data. We're starting to get slightly better data in community services, but yeah, it's very difficult with mental health, because of the kind of broad variety of patients that you have, and how, a person with schizophrenia. Some patients with schizophrenia can be quite a short, interaction. Some patients can be quite a long interaction. You can't easily differentiate between them. My wife is a psychiatrist, so I do have some insight into that. And then you can allocate resources in different ways. So you can take it from your job plans and then divide it and divide that accordingly. Okay. And again, for anaesthetists, it's really easy. We're sessional. And I do have some inside knowledge. We have it's sessional, and so it's I can only ever be doing one thing at a time. It's harder for some other specialties where you might do a ward round before you go to theatre, or you might do a ward round and then be doing a scope list, or you might be doing multiple things at the same time, essentially. And that's where it becomes a bit more difficult to kind of how you allocate your time. But it has to be done realistically on your job plan. And this is where there's a big push at the moment to ensure consultant job plans in particular are detailed and accurate. So you have your cost drivers, your weighted length of stay, how long you're in theatre for, number of patients, and then a weighted attendance. You kind of factor it. You have, some pages are more complex than others. Okay. What you can do with PLICS is you can get an idea. So I've used PLICS to try and help identify delays in treatment pathways. You can help it to justify. So if you want to do a service improvement, you can get them to model your costs before and after, and show you where the the benefits might be. It's PLICS is good at identifying problems, but you need the narrative to help solve them. So that's probably as with all data, you often need to use the data to identify problems, but you need to understand what the qualitative side of things to kind of come up with a problem, come up with a solution. But the first thing you always have to do when you're going through PLICS data is do some quality assurance, because if it's based on inaccurate data, then your whole analysis are going to be wrong. And we found there was lots of inaccuracies, both in terms of coding, both in terms of how it's allocated. Some of the assumptions, because there are always assumptions made, weren't true. And so now we've got slightly better data quality. It's not completely 100%, but it's better than it was. Okay, so there's lots of different ways of utilizing it to kind of improve your services. Okay, so this is an example where it's the standard TURP for prostates. So whilst the newer version was more costly from a consumable point of view, because they're quicker and can be done as a day case and has a lower complication rate, it'll be cheaper than doing the standard one where they're often in hospital for longer. You have TURP syndrome, all those kind of things that can happen. And so they've used their PLICS to show that. So this kind of PLICS database, every hospital has a slightly different one, and this is how we cross compare. You benchmark data against other hospitals, so you can see how much it costs you to deliver your service versus other people, and that's at you can request, anybody with NHS email address can request access to the national databases. Another good one is the model health system, which gives you lots of metrics to comparing, benchmarking yourselves against other organizations of similar sizes. Okay, and about on time. A quick another 10 minutes, so 9 minutes. We'll go till 22. We'll come back. I'll answer questions sitting here and wrap it on a bit more if anybody has any questions. But in terms of actual content, I'll give you another 9 minutes. 9 minutes to have a stretch, a break from my voice. I'll see you in 9 minutes. It's monitored. It's just not you can't do anything about it. Is the key thing. The idea is you can influence the next year's contract. That's the key thing. It's not that it's going to be completely ignored. You just can't change what's being paid for this year. What you then have to do is then make sure you factor it in for next year. So on either side. So if the demand is much higher, then you might actually go, well, next year I need to kind of factor that in when I'm doing my negotiations with the commissioners. No, because most of the data is now shared, so you can't really fake demand. You've got to show them the data. So that is, I mean, in theory you could, but it's the same thing as upcoding. So you can always overcode stuff to make it sound more complex, but you're not really doing anybody a favor, because then what happens is they kind of go, really? The commissioners will then analyze and go, really? And then they'll ask, you need to check it and they'll ask for the data and go insights. And then what happens is then everything gets questioned and then everything gets delayed and you end up not getting paid and you have cash flow problems. So pros and cons of trying to upcode or do things differently. It can be done both. So companies selling products in the NHS can be done either way. You can go centrally and become a framework provider. Okay, as I say, it depends on the type of product you're doing. So if you're doing something that people are going to buy masses of, like high volume stuff, syringes, small things, then you probably should go on a framework because they're more likely to do that. If it's one-off big items that are super specialist, like anesthetic machines or CT scanners or something like that, then you can probably go directly to the trust because they're probably more picky about that kind of stuff, and so probably more likely direct, do some assessments or trials and then do a assessment. Cash flow problems, you end up with basically taking a loan from the Department of Health. So you're not allowed. We're not allowed to just stop delivering services. We have to take loan. Essentially, you end up with a loan of some sorts. Special measures is where you're there's different. It's not called that anymore. So special measures is basically how much input or oversight NHS England or the Department of Health will give you. So, for example, if you are in tier 4, I think is the lowest at the moment, almost every big decision that's made has to be okayed by somebody at the Department of Health. Sometimes they even come in and sit in on the meetings. You get basically an external person kind of questioning you on every decision that's being made. Whether you're going to buy this, and often it's in the finance and committees that they sit in. And so you basically have an external person come down to troubleshoot and help. And it's just what degree of input and oversight they give you. Tier 1, you can do what you like because you've proven you're okay. And then other ones, they are kind of continually being questioned. Yes, and the simple answer, Lawrence, is that yes, loads of trusts are losing money just to inability to code properly. We found so pre-COVID, we found that that the allied health care professionals, so the physios and other places, were coding on a different system or a different. They were writing their notes on something that the coders didn't have access to, and there's lots of things that they do that affect the coding. Just walks of the Zimmer frame, this time, it's a lot of the kind of things that we don't as often, we may not think as important as clinicians, that they are important. It is important. Then you find that we found we were £10 million short. Now at that time the commissioners didn't have £10 million to give us, but we found that there was a £10 million shortfall in terms of how much we should have been paid. GP surgeries are also in GP and in emergency medicine, it's slightly different. They code, the clinicians do the coding. And one of the problems with GP, and this is where your weighted population stuff comes in based on a lot of their stuff. It's probably less relevant now because there's that population of probably. There's not that many of the population left that have this issue. But there was a period where when GP surgeons went from paper to digital, they got medical students or anybody who could type to translate that data across. And because some of the writing was really bad, it's really poorly done. So there's lots of records that have like weird and wonderful. You'll experience it across when you're looking at GP records or GP letters. There's some bizarre kind of things that are coded in there. It's big, and normally it's because when they went from paper to digital, somebody's typed it in, couldn't read it, and just put something in. You see these patients, you go, "Have you ever had this?" And you go, "No, they've never had that." So you have that issue. And same with it, it's less of an issue with emergency care because it's a slightly different payment process, and it is, yeah, they go into a different database, the emergency care data sets, which is slightly different, and there's fewer diagnoses available. So this is where the business cases come in. So how do you weigh the difference in importance of conditions? It's all about your business case, and it's a bit like Dragon's Den almost, but on paper. You've got to show why investing in a paying service or a new medical treatment, why one's more important than the other. They might both be important, but you've only got X number of X amount of money. So which ones do you invest in? And it's normally how well thought through business cases are. It depend. Yeah, well, that's where specialized commissioning comes in. So a lot of the tertiary services are specialized commissioning, which until recently has been NHS England funded, but increasingly is going to go to the ICBs. So yeah, they're part of the specialized service. There were 154 specialized services. Slowly, I think they've identified 80 that are going to stay as specialized services, and all the rest are going to go down to ICB level to be commissioned at that level. And then they'll be in the same pot. But yeah, the super specialized stuff will still be nationally commissioned. And the payment model for that will depend on what specialized services is. If it's well, it depends what it is. Again, it's about it depends who you're pitching your funding to. So I'll come to that in a minute as to who you should be pitching your funding to. So if you're a specialized service, you probably need to be pitching your funding to or your service improvement to the commissioners, whichever one they may be. Because if they increase their commissioning budgets, then that's fine. Yeah, there is on the NHS England website. I will find it and send it out to you. It's changed a little bit over the last couple of years, but there is a list of if you Google specialized services NHS England, there is a list. No, they probably. I don't know about complex regional pain services. I believe they probably are a specialized service. So they'll have two separate funding streams, one for the local delivery based on delivering X amount, and then one for your CRPS service. Okay. Business cases. So this is where hopefully we're going to try and put together a lot of the stuff that we've talked about already into how to improve your service. Now, there are business cases and there are business cases. So there are some that are multi-million-pound ones that you need all kinds of improvements for, and there's lots of hoops to jump through. There are smaller ones that you want to get, a much smaller pot. Historically, the quality of your business case does not necessarily align with getting funding. And that's because if it's already, so there are some situations where there is a trust or organizational direction, or it's been deemed that it's needed at trust level, and the business case is almost just a tick box to kind of show It showed the working, and you've already got your answer. But increasingly, that's not going to be right. And what I want to show you is how to do a good business case. So this is what we're going to talk about today is based on the public sector recommendations for writing business cases. It's called the 5-case model. It's part of the Better Business Cases scheme, which is run by the Treasury. And the whole thing is really complicated, and it's designed for large multi-million pound contracts. Now, what I've done is try and distill the essence of it down to what's manageable, what for us as clinicians. Okay, and I'll try and highlight some key things that we will need to be aware of. The first thing I'll say is we shouldn't be trying to write business cases in isolation. You will need help from finance, from HR, maybe from HR, certainly from operations teams, because you will not always have access to all the right data and the right information. And one of the things is that when you write a business case, and you can get questioned on it later, so you can get a business case through, and then a year or two down the line, when the service is losing money, you kind of go, well, what did you put in your business case? Did you not factor this in your business case? And then you're almost hamstrung by the fact that you haven't factored things in. Case in point, we have a robot, surgical robot thing that we rushed into. I say we, it wasn't me. They rushed into purchasing because it was bought with some charitable funds that a person had donated, but there was a time limit on the donation. And it's quite expensive. It caused a lot of disruption and has affected various other aspects of our delivery of care that we can do. But the key thing is that as part of the business case, they estimated how much the consumables were going to cost based on doing activity. But what they failed to appreciate was that there's a relatively long lead-in time where you're not doing the full amount of activity, or you are doing the time on the robot, but you're not doing the same level of cases. So instead of doing big bowel resections, you're doing hernias on the robot. And in terms of consumables versus income, you're going to lose money on it. And they hadn't factored that in. So it's not just getting the business case through, it's making sure it's done properly so that you can, it shows you your thought processes and what you factored in, what you haven't done. So that's the thing. Business case is not only a pitch for getting work or getting funding, investment, resource, whatever you want to call it. It is also a document showing how you've come up to your decision-making processes, essentially. Okay, so that's the two sides of a business case. With the second one probably as important as the first one, but is often not factored in or focused on. Historically, business cases were all focused on driving income, particularly in the acute sector. In acute hospitals, it was all about driving income. Now, that's kind of gone out the window because a lot of the commissioners, sometimes it does, but most of the time it depends on how much it costs and all that kind of stuff. Most business cases, the majority of business cases, should be written to address a problem. And conversely, most business cases are written with an answer in mind rather than just addressing a problem. Now, it's one of the things that I offer to people is to look at business cases. And now it's very obvious when a business case has been written with an answer in mind, because that particular area has been well thought through, but nothing else is. All the business cases entitled, it's a solution with a solution. Okay, so if you can write a business case to solve a problem, your thought processes will be much better. There are occasions where you can put a business case to improve quality, but it has to be a significant improvement in quality. As I was kind of mentioning briefly earlier, you've got to understand what processes you've got to follow. What hoops does your organization have? Because everywhere is slightly different in terms of how, who they need to speak to get their business case approved. You'll obviously need your head of department. You might need somebody above that. You will need support from other people to push the business case through. Okay. Who are you going to be pitching to? Is it going to be an internal business case? Is it within your department? You're looking for reallocation of resource. Are you asking for extra resource from the hospital, or are you asking for a whole new service, which in case or expanding your service and how much is commission, in which case you're looking at the commissioners and you're going to be pitching to them. So there's different levels of business cases and different hoops you're going to have to jump through to kind of depending on what it is you're going through. Work out who the best people you're going to be targeting are. So if your business case is primarily to improve education, then look into educational funding. If it's a patient safety thing, there might be patient safety funding out there nationally. So just look at where not just the standard income streams, there are other funding streams available out there. And your finance people should know about them. So in a business case, you want all the kind of who, what, where, when, why, but we're going to try and do it in an organized fashion. Okay, so this is where this 5-case model comes in. It has something called the strategic case, the economic case, the commercial case, the financial case, and the management case. Now, us as clinicians will be focusing more or less on the strategic case and a little bit on the economic case and touching upon the management case. The commercial case and financial case is where you need your help from your various procurement or HR and finance teams, because that's specialist knowledge you'll need. Okay, because it is quite complex in those things. So I'm going to spend a lot of time on strategic case, a bit less time economic case, but some time on that, and we're going to touch on the other bits. And because they're the bits that you probably need special advice on. I'll show that in the end because that's a summary, but the strategic case is where you have your context. Okay. What you need to show is that whatever business case, whatever plan you have matches whatever the organizational aims are for that particular year or that kind of your strategy. So if you've got an organizational strategy, if you've got a priorities for the current year, you've got to show very early on how what you're doing is going to align to that, how it helps them achieve that. Okay. You can call it creative writing, but essentially you have to match it. If it's going to be negatively affecting any of those things, it's going to get deferred or rejected straight off. Okay, so early on, align it in simple English: organizational aims and ambitions. The other big thing I would say is when we as clinicians are writing business cases, we are probably subject matter experts, so we know all the different things and all the terminologies and things like that. Some of the people, or lots of the people reading business cases, will not know the level of detail you will. Okay, so try and explain different complex areas and try and keep it relatively simple if you can, because one of the things is if it's not dull to read, business cases aren't and very rarely interesting to read, but if it loses you because you can't understand the terminology, you're not going to get engaged in it. You're not going to think this is a good idea. And sometimes if you depending on the time of year, if you've got 7 or 8 business cases to read and they're all multiple pages, you're just going to dismiss the ones that you can't understand. This is probably one of the most important bits. It's your case for change. Why should we prioritize getting this business case over all the others we have? It's not to say very few business cases are bad ideas. Okay, it's why is this important? What is it going to achieve? What we want to achieve, want to achieve. Okay, so when you're staking your case for change, use benchmarking data. So model hospital is really important. It's a good way of doing things. Or the model health system, as it's called now. Any CQC recommendations are always quite powerful. The GERFT is the getting it right first time reports. They can be quite powerful because we get told off about them. I would say that and root cause analysis can be useful. I would say one of the lower level recommendations are the NICE and Royal College recommendations. Okay, because there's no time limit on those. There's no imminent. They often are quite vague and say that this is what we should do, but you often go, but it doesn't give you a priority. And if you speak to people on these kind of who kind of review business cases, they'll say, well, the Royal College has come up with recommendations. There's like 20 Royal Colleges, each coming up with recommendations every year. We can't prioritize all of them, and similar way to NICE. If there's some absolute mandated stuff, then yes, they get prioritized. But just the recommendations are just that, recommendations. Mortality reviews can be powerful. Coroners reports can be quite powerful as well. So all of those things can help your case for change. Again, unfortunately, anaesthetic example, but this is from my data. So desflurane is a anaesthetic gas. We were quite high users of it. We were way above the national average a few years ago when I took over as sustainability lead. And I use this. This is from the model hospital. And I use this to get some more pumps for delivering an alternative way of giving anaesthetics. And within a year, we completely taken desflurane off our shelves, and we're now desflurane free. But it's quite a good way of demonstrating where the issues are. What's the problem? Okay. Another, again, this is slightly old, but probably still applies. We probably haven't sold it completely. So one of the issues here is that our trust is the black line, so it's towards the kind of the bottom end. So it's a length of stay of less than 2 days for emergency appendectomies. Now, if you then looked at the data a bit more, you then found out that the reason for that is that our patients didn't get to theatre until day 2. Not that we had problems post-operatively, they just didn't get there. We didn't have enough emergency theatre capacity. So you can use that, and we did, to increase our emergency theatre capacity. Okay, so use the data to show the problem, so then you can then come up with help find answers. So the next bit, apart from once you've done the kind of case for change, you have to put your existing arrangements. So what is your current situation? What's your current setup? What do you kind of have in the how you're delivering the services it is? The business needs, current and future, are thinking about your demand and capacity. So what's your current demand? How has it changed? Is it likely to increase further? Is it going to be accelerated? And what your future changes? Okay, so we'll come to how to do a demand and capacity assessment, a simple one, in a bit. What's the scope of your plan? Okay, so what's the scope of this business case? Is it a massive business case trying to build a whole new hospital, or a whole new building to improve what you're doing? Or is it just a staffing model thing? Is it just that you've got the states, you just want a staffing issue? Okay, and what are you then going to spend the money on? Is it staffing? Is it equipment? Is it a combination of things? So your scope and your spending objectives are related to, what's the extent of this project and what your objectives. Okay. Constraints and dependencies are what's going to limit you, and for most people it's either staffing or it's estates, so just space. So most people's constraints are staffing or space. Okay. So yeah, and dependencies are where one business case or something is dependent on something else. So you might have one business case that if you don't get approved, it's like a stack of cards, and everything else will fall apart around it. Okay, so what else is dependent on this business case? Benefits, risks, and there's a word called disbenefits, which is a bad word, but it's what's used in this context. So benefits are obviously what the good things are going to happen. The risks are things that might happen, the bad things that might happen, and the disbenefits, odd word, but it's the bad things that will happen. You might call it an unintended consequence, or a side effect of the benefit. Okay, so an example. So as I said, sometimes we do these things where we have like a Dragon's Den pitch. So people come and pitch an idea, and we kind of go through it and not pick it apart, but give advice on how to improve it. And somebody came, a radiologist came and talked about a different way of doing the breast cancer screening that involved injecting cannula, injecting something in, and then imaging afterwards. It had great specificity and sensitivity. And then we talked about it, and I said, well, okay, so how many patients are you going to get through a session? How many patients do you currently get through a session? How many patients are you going to do with this new system? And obviously it's more time consuming because it involves cannulation, injection, and imaging. So it's fewer patients. So I said, unless you then factor in or increase the amount of activity you're doing, you might struggle to get this through, because it's going to have an impact on your breast screening waiting lists. Because once it's more sensitive and specific, if you're not seeing as many patients and the waiting list is going to grow, that's not going to be, that's a disbenefit. So you've got to mitigate it. You've got to put in some sort of mitigation. So you might do an extra long session or whatever it is, so that you can see the same number of patients. So disbenefits are bad things that will happen, side effects. And that's the word they use. Okay, so demand and capacity modeling is a simple way. I mean, this is one from an X-ray system and radiology system, but essentially is looking at the change. So you have your, look at historical data, look at how much activity you've done per year, look at the change, and then predict. You can have a conservative and an optimistic forecast, but forecast how much of that's going to change. It's always useful to factor in 2 or 3 years in advance when you're making these things, because what you don't want, and what is really doesn't go down well, is when you do a business case, get it approved, and then next year you have to go and build another business case because you've not factored in changes in demand. Well, you just had a business case approved last year. Why are you coming back for the same thing again? So it's always worth factoring in at least 3 years in the future, to make sure that you can actually take that into account. Going back to say with the same business case is not great. Again, you can just use this as a way. You can look at a number of additional lists, how many patients are seen. The bit on the grey depends on the funding system, whether you get extra money for it or not. But that's just a way of looking at how your capacity side of things will need to factor that in. Okay. So you've kind of put your pitch across what the issue is and what the problem is, why things need to be prioritized, why it's so bad. The next bit is your long case, which is what your options are. Now, again, you are the experts. You will know all the options that are non-starters, and you won't even write them down because you think, oh, that's a stupid one. But again, think about if you're looking at it from outside the your speciality, then you might find that they come up with ideas and they go, well, why don't you think of this? And you go, well, it's non-starter. But if you write it down as part of your long list, if you kind of write down all the weird and wonderful options and then explain why that they're non-starters, then you can knock down your long list down to a more reasonable number. Okay. And how you knock them down is your assessment criteria. Now you can do it. There's so many different ways of doing assessment criteria. You can weight them. You can do critical success factors. Is basically your if you've seen job descriptions, you have your essential and your desirable. The critical success factors, your essential. You might then have some desirable options that, if in an ideal world we want this, but these are the must-haves. Okay, and then you get your long list down to a short list. You probably need at least 3 or 4 options, including a kind of minimum option. And if you're struggling to get down to that, we'll come up with. I'll show you a way you might be able to do that in a bit. You have economic appraisal. So what are the benefits? So your qualitative benefits. Looking at for each option, what is the degree of benefit you're going to get. Okay, because some may only give you smaller benefits but are cheaper, but others may give you massive benefit, but even though they're more expensive. Okay, so it's a qualitative assessment of your benefits, and then a rough cost appraisal. You're not getting the details. You just want to know, roughly how much it's going to cost. So that goes in your economic case. If you are struggling to come up with options, as many of us do, what you can do is do this kind of table. And the example I use, because we have lots of different, I'm trying to not be so surgery and acute system focused, is to go completely off tangent and do, we'll do railway capacity between London and the rest of the country. Okay, so that's the problem. We are insufficient railway capacity between London and the rest of the country. That's our problem. What are our options? Okay. So the minimum option, the what, is to improve the railway between London and Birmingham. Okay. The maximum is to improve between London, Birmingham, the northeast and the northwest. So or Yorkshire and the northwest. Okay. So, and the intermediate is somewhere in between. So London and either the northwest or the Yorkshire. So there's your what. So what extent, how big a thing you can do it. How? So how can be, related to the staffing model, not the staffing model, the how frequent you're going to do it, how you're going to do it. So the minimum would to refurbish in our scenario, refurbish the existing track. The maximum would be to build a whole new track. Okay, and the intermediate is to do a combination of the two. Okay, so the who is who's going to deliver it. So this could be about your staffing. So is it going to be delivered by a consultant? Is it going to be delivered by a consultant and a nurse specialist, or nurses, or a consultant registrars? Who's going to be delivering this service that you're asking for? In this scenario, it's going to be a local contractor, and a national contractor, or an international contractor. That's basically in this scenario. But in the kind of clinical scenario, it's which staffing model you're going to use. The when is about how it's going to roll out. So you're going to do a big bang all at the same time. It's all going to start. We're all going to do it all together in one big process. The minimum would be to do one bit first, and then another bit, and then another bit. And then the intermediates to do, start from one end, start from the other, meet in the middle on one of bits, and then join the third bit. Okay. But for the purposes of clinical stuff, it's, you can do a pilot, are you going to do a gradual rollout over a period of time, or you can do a big bang, massive switchover. Funding is, where's the funding coming from? Is it internal funding? Is it educational funding? Is it coming from, which funding streams is it coming from? Okay, so if you've got a service that's got both local and national specialized funding, where is it coming from? Are they coming from slightly different ones, or a bit of both? In this scenario, in the kind of railway scenario, is it going to come from public money or private money, or a combination of the two? And so what you then do is you kind of go look at your key, your essential criteria, and you color in, you shade the red boxes that are the non-starters, and you explain why the non-starters in the text below. You have your orange as possibles, and your green as your preferred, and you then explain why you've chosen what you've chosen. Why is this your preferred? Why are these options available, and why is this one your preferred? Okay, and therefore you've got a good rationale of why you've chosen which option you've chosen. Yeah, so that way you've done a whole options appraisal. Now there are different ways of doing it, but this is a suggested way for this particular type of these business cases. Okay, so we've covered the strategic case. Is it needed? Why we need to change? What are the risks and benefits? There must be something about a quality improvement, so where the quality improvement is. Is it value for money? So that's where your qualitative versus cost appraisal comes in. What options have been considered, and which option has been chosen, and why? So it's almost the other way around. So what options have been considered, which option has been chosen, and why, and then is it value for money? That's probably the order it probably should be in. Okay. Procurement is, as I said before, is a very variable feast, and you need specialist knowledge, because different people will procure in different ways, and depending on the size of your what you're trying to do, then you might find that you have different procurement requirements. The key thing with procurement is to look at the whole life cost. So what that means is you might have something that has a high upfront cost, but a low consumable cost. So each time you use it, the consumable element is not done very much. Now, that's great if you're not using it very much. Okay, but if you're using it loads and there's a high consumable cost over the lifespan of the product, then you might be spending more. Or if you've got something that's got a low that's all around. So if you're using it a lot, so if you're not using it very much, you want the low upfront cost and the high consumable cost. If you're using it loads, you want it the other way around. You want the lower consumable cost and the higher upfront cost. If that makes sense. You can just look at how much it costs, depending on how much you use it and over what kind of time period. There's no point signing up for a contract that's going to tie you up for 10 years when you know the next is going to get an upgrade within 3 years, unless that's built into the contract in your procurement. Personnel requirements. So depending on what you're requiring. So when you're trying to calculate your requirements, the traditional way of doing it for consultants is on a 42-week delivery. So because of annual leave, study leave, and various other types of leave, the standard way of delivery we traditionally use as 42-week delivery. So if you want a clinic every day of the week, you need 1.2 working time equivalents. Okay, the exact numbers will come for personnel. If you want nursing staff or anybody else on the agenda for change contracts, which is basically anything other than medics, their contracts based on a 37.5-hour working week. Okay, so if you have you want an extra nurse for a clinic, you've got to then factor in how much of a working time equivalent that would be from their contracts. Okay, so that's where your personnel requirements and HR templates come in and can be quite useful. The contract issues are all about making sure that so if you have a contract for syringes, for example, with a company at national level, organizational level, if you want a specific type of syringe, if the company that you've contracted with already has that, you're going to have to go with them because you probably have a contract with them. If they don't have them, or you want to use you think another company's syringes are better, then you may be able to put an exception in, but you may have to wait till the contract's renegotiated. Okay, and then make sure your needs are factored into that request. Okay, so that's one thing. The other thing you might find is that there's incompatibility issues. So we bought a particular bit of equipment, an exercise bike testing thing, and it's got a computer built into it. Now I'm gonna use it as a Dell. So we're going to say Dell, for example. So it had a Dell computer base into it, but the rest of our IT is all run is supplied by HP. And so there were compatibility issues with the drivers and getting it all network synced and all that kind of stuff. So it delayed 6 weeks to get that up and running because of that compatibility issue. So you might find there are issues with compatibility or existing contracts. So just to be aware of this. How are you going to pay for it? So if you're going to say this is going to save you money, over what kind of time period is it going to save you money? Where's the money coming from? Is it coming from internal? Is it coming from commissioners? Is it coming from educational funds? Just be clear where it's coming from. How's it going to be delivered is all about that rollout we talked about in the options appraisal. Impact on service delivery it's a combination of what are you going to do during the changeover? How are you going to mitigate it? Is there any key steps that may derail the process and what you're going to do in that situation? Is it going to help? It's useful to say at this point, is it going to help other areas? If you're going to you're going to create a extra specialist neurology clinic looking at movement disorders that were previously seen in the general neurology clinic. Is that going to increase their capacity to see general neurology? Is it going to reduce the general neurology waiting list as well as the movement disorders waiting list. Yeah. You know, what impact is it going to have on the other services? If you're doing a big changeover, so we had reconfiguration, we moved our peds cardiac from one site to another. During that period, we had to make sure that there was maybe 2 days where we couldn't deliver emergency care. So we kind of said, well, if any emergency peds cardiac surgery needs to happen, we asked Birmingham to cover us. Okay, so you can have to mitigate for any issues during that process. So it is all about factoring that in. Try and identify all the people that might be affected or impacted by your business case or your whatever solution might be. Okay, get them to get involved. The more support you have and the less barriers people put in, the more likely it's going to get pushed through, particularly if it's coming from different specialties, different directorates. Okay. People don't like change, so you might have to, if you get their support and get them buy-in early on, then they're more likely to help push it through. Other slightly tips are timing can be important. So if you have a small business case that's mostly capital, so non-recurrent funding, a one-off purchase, sometimes some of the other capital projects might have slightly underspent, and there might be small pots of money available, okay, for small bits of equipment. Okay, so that those extra pumps that I got as part of that sustainability thing comes from a sustainability pot that the commissioners had, okay, at the end of the year, as they asked for invitations to people to pitch for money. If you're looking to start a whole new service and you want commissioner involvement, then you need to plan to start from the start of the financial year. It's much easier. But remember that discussions can start the previous year. Okay, so think about timing. Also, when you think about implementation, think about recruitment timing as well. You can remember that for a consultant job, if you're looking for a new consultant, you know, people can apply from 6 months from their end of their CCT, you know, away from CCTing. So you might have a 6-month lead in before you can have somebody can start. And then if you factor in the fact that you've got to put it out to recruitment, you've got to get through recruitment hurdles, you've got to get Royal College approval for your job if it's a substantive job. You're looking at maybe 9-10 months to get a minimum, to get a job, to get somebody into place from once you've got your business case approved. If it's a nursing thing, then you might be a bit quicker. It's slightly less notice periods for those people, particularly if it might be coming from an internal recruitment, because if it's somebody getting promoted into a higher band job, that might have a lower level of timing required. But then factor in that timeline. There's no point saying, oh, I want my funding to start this year, but then you don't actually recruit until the next year, because then they might go, well, you need to spend it now and not then. So look at the timing. Look at like I said earlier, look at alternative source of funding. You get digital transformation funds, you get patient safety funds, you get education funds. The difference between system and specialized funding is decreasing, so because it's often going to the ICBs anyway. And then if there is a related larger business case, so if you're having a new building built or some big business case that's multi-million-pound, a small bit extra few things that if they're related, you can probably get in without any issues. So that's probably one of the other big things. If you've got bigger business cases going on, try and combine it. It's more likely to get through. That's it from me. In terms of what's I've kind of pre-prepared. Let me know if you have any questions. Feel free to email me. Happy to answer any questions. I said you'll get the slides through. We do some slightly longer study days, but the first and last session are basically the same as this one. Some of the in-between ones may be of relevance, but you're probably better off watching them on YouTube rather than having to go through the whole thing again. Hope you found it useful. Oh yeah, course and study days. There is the HFMA have a publication, a book, or some sort of glossary thing that's basically A to Z, or not an A to Z, a guide to NHS Finance. So it's a kind of a booklet form of part of my talk. There is various bits of links and stuff on in terms of finance on NHS, on the One NHS for Finance website. It's got links to some courses and stuff like that. HFMA do some e-learning modules. I think 5 of them some of them are free, some of them you have to pay for, and you get a small little certificate on various aspects of NHS Finance. In terms of other aspects of leadership management courses, I would say a lot of the new consultant stuff probably need to do, it's more specific to do it in-house in your own organization and see what how they run, because now you're committed to a particular organization. It's probably useful to kind of see what they do. The King's Fund have some kind of high level interesting talks, but it's more for people who have actual decision-making power rather than for new consultants. What else? That's probably most of the advice I have. Yeah, if you email me any specific questions about that kind of stuff, if any specific areas you want, I'm happy to answer some questions. So I'll be here for another 10-15 minutes if you have any questions. But if you don't, then feel free to use it was on my last slide. It's my name, akiban.maheswaran@nhs.net. Lawrence, driving it was commissioners. It was all about, because it was all activity-based funding, everything was PBR, activity-based, emergency and elective care was all activity-based. So if you drove, so because the whole concept of costing wasn't a thing, and so nobody really factored in that you might be losing money. You might get more money coming in, but it might cost you more to deliver that service than the money you're coming in. And that was the problem. So particularly in some specialities, they were going, well, this will give us more money, this will give us more money. And that was prioritized, even though if you looked at the detail, you probably lose money on each of them, on each patient that came through. That's the part of the problem with outpatients work as well. That's why there's a whole big drive to reduce the amount of outpatient work, because a lot of it loses money. Apart from that first assessment, everything else you lose money on, every follow-up appointment. You're benchmarking against other organizations delivering the same kind of stuff. So, for example, if your organization is an outlier in whatever aspect, then you're benchmarking against your peers. Ideally, similar sized hospitals, but that's where the model health system comes in, because it will benchmark you against other areas. So that's the best. Outpatient or inpatient bed. So if you're shifting somebody from inpatient to outpatient, that's beneficial. But so things like same-day emergency care stuff is good. It's the repeated follow-ups. So first attendances you make money on. Follow-up appointments, whether inpatient or outpatients, tend to lose your money. So yeah, if you can get them out of hospital, that's ideal, and that will benefit you. But your income for outpatient reviews, repeated outpatient reviews, that's the problem. It's where the best place for them to be seen is. Is it a consultant review? Is it somebody on the end of a phone? Is it for pain patients? I mean, pain's a difficult special area to talk about, because it is an area where funding models are decreasing. So, apart from specialist centres, general local pain services are decreasing, particularly interventional pain services. The funding's decreasing. We're lucky, and lucky slash, I don't know, depends which point of view. We're still quite well funded for interventional pain, but in other areas it's not so. It's not, the funding's not as strong. But yeah, so again, it's who sees them. So if you, tertiary pain services are staying the same. Community DGH pain services are probably shrinking, and with the argument that private chronic pain services are growing. In terms of it also depends on who's seeing them. Repeated consultant reviews will probably lose you money. If you can do a telephone consultation or a support worker or specialist nurse-led consultation, you might be able to get that money back or break even. It's all with it depends on your exact nature and how many patients you're seeing in that period. Essentially, consultants have a high cost, so therefore, if you see 5-10 face-to-face patients, whereas if you can see 15 telephone patients and it's done by a nurse, that's going to be cheaper both ways. A quality case must show that you're basically showing there's an improvement in quality and all the different areas. So so a quality case, you have to show there's improvement in clinical outcomes in patient satisfaction and patient safety, or what the degree of improvement is important as well. Yeah, so with the pain, it's all about where it's best delivered. It's whether it should be done at the hospital, whether it should be done in the neighborhood diagnostic center. Yeah, it's top part of the value catcher, where it needs to be delivered. That's the key thing. Whether you call it outpatients, whether you call it outpatients at the GP, and who delivers it. That's where the cost issue comes in. Yes, not being an inpatient's good, but it's then who's delivering it and how you're getting reimbursed for that. I'm not a pain consultant. I don't know the intricacies. I just know the general feel. Interventional pain programs are the problem with the interventional pain programs. It's the evidence base on a patient level is good, so individual patients will show benefit, but if you will you may not be able to show the evidence base at higher levels. So if you're trying to go, you're not going to get randomized controlled studies. The number needed to treat will be high, all that kind of stuff. And there is in other parts of the world, there is a push that well, in developed countries, there's a push that those services don't exist, and that actually the pain management programs are probably have got a stronger evidence base behind it than the interventional. So it's not to say that there are certain interventions that are very good, but there are a certain degree of interventions that are the evidence base is not strong, so the commissioners don't see the benefit. Yeah, I'm not disagreeing. I'm just telling you what the commissioner's viewpoint is. It's not my personal viewpoint. It's just a having been in some of those meetings, this is where the pushback is. Potentially, yeah. you'd have a stronger argument to increase funding. Your business case pitch would be better. Generally, no. I don't know whether commissioners' meetings are made, the minutes are made public, or those decisions are made. Because it varies so much between different organisations. I think you probably have to speak to a pain lead and see what they say, because they'll probably have that information. The HFMA have have a whole e-learning series, and they do. I mean, they do courses as well, but which may or may not be useful for you. But they have some good e-learning modules. That's the HFMA UK site you want. Right. It's 12:30. Last call for any questions. Otherwise, enjoy your afternoon. Enjoy the rest of the October. Thanks, Lily.
Thanks, AK. Have a great holiday.
And yeah, thanks.
Cheers. Bye-bye.
See you later. Bye.